Thank you very much, everybody, for joining us today. I know that it's the last day, the final day, third day of the conference, and it is late in the afternoon. So we really appreciate you being here with us today. And also I would like to thank everybody who's with us live, because we are broadcasting this live on LinkedIn. I hope you enjoy the engaging conversation and discussion that we are about to have. Today's panel discussion is going to be about personalized care and how personalized care impacts your health span. And maybe before we get right into it, I will ask our panelists to actually introduce themselves. Maybe we will start from here, left to right. Dr. Nicole, please.
Welcome everyone. My name is Nicole Sirotin. I am an internal medicine physician, and I'm our CEO of the Institute for Healthier Living Abu Dhabi. And I thank you. In need of some microphone training. How's that? My name is Nicole Sirotin. I'm our CEO of the Institute for Healthier Living Abu Dhabi and former chair of preventive medicine at Cleveland Clinic Abu Dhabi. And I'm delighted to be here. Thank you.
David Katz, microphone support professional. I'm a preventive medicine doc, lifestyle medicine specialist, past president of the American College of Lifestyle Medicine.
Hi everybody, my name is Phil Newman. I'm the CEO of Longevity Technology, and I analyze the industry, and looking forward to sharing some information today. Thank you.
Thank you.
Andrea Maier, I'm an internal medicine specialist, health and longevity medicine physician. I founded Chi Longevity and really trying to build the ecosystem to bring optimizing health to all of us, to lots of nations, democratizing health.
Thank you very much. Maybe I will just briefly introduce myself for those of you who don't know me. So my name is Hinda Daggag. I am the director in Healthcare Business Unit at PwC, and I am really honored to be here today with you guys. So maybe Dr. Andrea, we'll start with you. I promise I'm not picking on you. I know I started with you also 2 days ago. We end up doing with you the terminology and the definitions. So maybe let's do that again. It went well 2 days ago. So in order for all of us to kind of be aligned and to understand exactly what the panel discussion will be about, perhaps you can define to us what do we mean by health span in this context, and what do we mean personalized care in the context of health span?
Yeah, great question. I think we have to coin four words: that's health span, lifespan, biological age, and chronological age. Let's start with lifespan. So that's the number of years we have. The health span is very different, and that's the healthy lifespan we have. There are definitions that it stops at the point where the incidence of disease occurs. So which means it's most of the times in countries at the age of 50, because then diabetes, cardiovascular diseases, dementia a little bit later, but these kind of diseases kick in. So that's health span and lifespan. Then we have biological and chronological age, which is very, very important for this topic about personalized care. So the chronological age is quite clear. The biological age is different, and it depends on the pace of aging of a person. So the biological age is really determined by biological processes in the body, and you can be younger or older. So very importantly, at the age of 50, data shows that you can be 3 or 6 years younger or older compared to your chronological peers, to your chronological age. So biological age is very important. How do we measure biological age is a different question. It's quite in the discussion at the moment. We have clinical, biological, and digital markers, and based on that, and that leads to our topic, we can define the intervention, and that leads to precision medicine, which we are applying at the moment in the area of health and longevity medicine, which is defined, last definition, as optimizing health by antagonizing aging processes across the lifespan. So really targeting aging processes at the root cause to prevent age-related diseases, to therewith have a longer health span, and possibly as a side effect also lifespan.
So is the term precision healthy longevity a thing? Is it the right terminology to use within this context?
I think let's do not make it complicated, and let's do not stick with, I think having good terminology is important. if everybody here already would know what health and longevity medicine is, I think we would already be set. Yes, adding precision to it is, I think, the goal. Really knowing how to influence biology of aging individuals and bringing that into clinical practice. For me, the outcome is most important to optimizing health for as much as possible. The number really counts, not the way how we get there.
Yeah. Okay, so when we are talking about personalized care, how do we really establish it? You know, what do we have in mind? Because does that mean that, you know, the one size fits all concept does not apply anymore, and we need to move away from that? I think you also use the example of WHO standards for 10,000 steps, you know, for average steps on a daily basis. Are we moving away from that and we are trying to tailor the approach more?
Absolutely, but I want to make sure that everybody understands that every clinician is doing personalized care, because if we have somebody in front of us, we are personalizing it. I think what we have to achieve is bring precision to it, because personalization is very often, we look at someone, we say, okay, maybe a little bit less or a little bit more. Yeah. That's what we do. How do we get to a point that we bring evidence base into it and being as precise as possible and making clusters of individuals that in the end, every individual is actually a cluster, that we have the precise therapeutics and diagnostics for that individual.
Yep, that makes sense. Okay, so I think maybe building up on that, Dr. David, we can move on to you. And would you be able to tell us a little bit more, or the best ways really to personalize care, especially within the context of lifestyle medicine and even more so nutrition?
It's difficult to talk about precision or personalization without establishing a bedrock underneath us all. So one of the things I like to emphasize is that we're all related. This is one big extended human family. We're certainly all the same kind of animal. We have the same basic biological requirements. And so part of personalization is to respect the commonality first. What do we all need, right? We all need to breathe the same basic atmosphere. We all have the same basic requirements for water. It stands to reason that the other components of lifestyle, the amount of sleep we need, more or less in common, the ways we're stressed out and the things we can do to dissipate that stress, sort of a short suite of options accessible to us all. On that list of things that prevail for all of us, the top three in the literature would be tobacco use, bad; diet quality, unfortunately all too often bad, but has the potential to be very good; and physical activity. And then followed by sleep, stress, social connections. I sort of characterize what we do with our feet, our forks, and our fingers as the top three. And I credit McGinnis and Fagey 1993 paper in the Journal of the American Medical Association, Actual Causes of Death. So my initial thoughts about precision and personalization are to establish these common destinations: avoidance of tobacco, optimizing nutrition, optimizing levels of physical activity, and then if we extend the list, adequate sleep, avoidance of excessive stress, strong social connections. How do we help people get there from here? And that's highly individualized. And we could even think in terms of what is the set of impediments you encounter in your daily routine, unique to you in all the world, that make eating well at any given occasion hard rather than easy? What's the set of impediments you encounter in your daily routine that makes it difficult to get in the requisite amount of physical activity? What are the things that happen to you routinely that tend to sabotage the quantity and quality of your sleep or impose excessive stress? All of that's clearly highly individualized. The area where I focus my attention preferentially is diet nutrition, because on that list, feet, forks, fingers, sleep, stress, and love, the one where people are, in addition to the other barriers, generally lost and confused is nutrition. Right? Everybody knows that smoking is bad. They may do it, but nobody's really confused about it. Whereas diet, everybody's lost and confused. Everybody has a friend's brother's cousin's sister who has the best diet advice this week, and so we're constantly chasing silly tales. What's important there, and then I'll happily pass the microphone along, is that optimal nutrition is a theme. Real food, mostly plants. Lots of vegetables, fruits, whole grains, beans, lentils, nuts, and seeds, and when you're thirsty, plain water. Basic formula, spoiler alert. But we have a beautiful variety of cultural approaches around the globe to that same formula. And we should not be thinking to impose one size fits all, nor one taste fits all. So we can actually help people adopt the theme that we all share, because we are one common human family, we are the same kind of animal, and we can be extremely precise about the prescription for an individual based on their tastes, their preferences, their upbringing, their heritage, their culture, and a lot of detailed information about their biology. And all of those are potential filters to say, we can optimize the variant on the theme for you. Optimize it in a way that is adapted to your particular biological needs, fix what's broken, if you will, but also importantly, adapt it to your tastes and preferences so that you can love the food that loves you back.
So maybe I will ask you just one more question on that. So we know that different people will, I guess, react to different foods differently, metabolize different food differently. Where does genomics or genetics fit into this? You know, there's quite a lot of, obviously, buzz about the nutrigenomics and doing all of these tests that are going to help you, tell you what you should eat, should or should not eat. So number one, what do you think about all of that, and where does it fit in this picture from what we are talking about today?
My colleagues on the panel may differ with me to some extent, but I think we know most of what we need to know about the dietary prescription before we get to the level of nutrigenomics. We have some number of SNPs that are relevant, and then there are clearly sensitivities that we have to respect. So I would recommend whole grains as part of a healthy diet, but if someone has a gluten intolerance, we obviously want to avoid all grains that contain gluten. So you have to honor and respect those biological variations, clearly very important. Some people can safely digest dairy products and want them as part of their diet. Some cultures exclude dairy altogether. And in those cultures, most people are lactose intolerant, which, by the way, is the normal state for adult mammals. Being lactose tolerant is a genetic mutation. Long story behind that. We can talk about it later if you like. So the SNPs that we have to offer precision nutrition, I think, would be the fine-tuning on the dial. First, we want to know, what are your basic health objectives? What's your current health status? What do we know about it? What are your health objectives? Do you need to lose weight? Yes or no? Do you need to reduce inflammation? Yes or no? Are you working to manage symptoms of menopause, optimize cognition, improve athletic performance? What do you want a better diet to do for you? That's clearly personal. What kinds of foods do you like to eat? What sensitivities, allergies, or intolerances you have? We don't need rarefied information to get personal at that level. So the coarse adjustment of the dial is information that hides in plain sight as long as we ask the right questions. The fine adjustment is the additional filter of what we can derive from nutrigenomics, microbiomic analysis, metabolomic analysis. We may gain additional insights there to say, actually, you'll do slightly better with a bit more of A and a bit less of B, and I don't presume to say what that is, because that would be highly personalized. The same basic theme would pertain. What we can't lose sight of is that in the world at large, here in the UAE, in the US, hardly anybody's on the theme. We could do a massive amount of good by moving people in the same general direction, and then we can do additional good by being highly precise with individuals. But from the perspective of population health, we have miles to go just to get people in the right channel in the first place.
Yeah, fair enough. Sometimes it's much more simpler than we make it to be. Like if we start from the basics and then move on, it would help. Thank you very much. Phil, maybe I can ask you one question regarding obviously your field and the, I guess, the technological advances in general that are taking place, such as genomics, if we're talking about sequencing and everything else that fits within that. Can you maybe tell us a little bit more from the technological aspect, what is taking place within the longevity ecosystem, and how are basically really the tech-enabled advances moving the precision care or personalized care within the longevity field, such as, I don't know, wearables and many other ones. Sorry, you had to do a bit of shouting, Phil, but
Projected from the diaphragm.
and I also think about my 10-year-old son who watches me, you know, when I'm exercising, who asks me about what this is, the device that's on my wrist, you know, and I explain to him. He sees kind of what my lifestyle is, you know, and I'm very hopeful that that is actually, you know, just like you said, for the older generation, it's kind of similar for the younger generation, where they're going to pick up on all of these habits and it's going to become a norm for them. And I think it's very exciting.
Yeah, and the damage starts so early, right? So the point is, and this is very important for our industry, that the education is not for the middle-aged upwards, right? We want to be starting super early. And I've been talking about this whole region, okay? So there's a beautiful population pyramid here, lots of young babies at the bottom,
Yes.
fewer old people at the top. This is a great opportunity to really get it right and then spread that education around the world. And I think it's very exciting, the work that's going on here.
Absolutely. Thank you very much for that, Phil. Dr. Nicole, we will move on to you. So it's very clear from our discussions that there are more tools on a population level that we can now apply to personalized care in general, whether we're talking about healthy lifespan or just in general in medicine. So, but we can't kind of forget where all of this has started, and that is the field of oncology, really. That is kind of where it was initiated. So maybe if you can just tell us a little bit more about the origins of it, the start of it, and, you know, how has the oncology field really helped advance the precision medicine and personalized care?
Yeah, thank you. Thank you for that. And thank you to everyone. And thank you to all the patient audience. So oncology has been the area of medicine that really has been able to take the concept of personalization into a model of care. And I think we've all been hoping for personalized medicine. We've been discussing personalized medicine for many years. And those of us that see patients regularly, we know that we have clinical trials that help inform guidelines and societies that come together and say, if you have this is your step 1, your step 2, and your step 3. Those are all based on population studies or clinical trial studies that inform our decisions, our clinical decisions. And at the same time, we have an individual in front of us, and we have to, as Andrea said, we do a little more, a little less based on that person's their own ecosystem. And so what oncology has been able to do is understand that tumors are different, that tumors act differently in different humans, and that we need different treatments based on the specifics of that tumor. And so we now have treatments that are very expensive and still slightly experimental, but are actually able to take tissue from a tumor and tailor the treatment specifically for that tumor in that human, and with the idea that that's going to be the best benefit for that one patient, right? Because we constantly have this struggle between how do we benefit the one human in front of us and how do we benefit the population. And even when you look at our cancer screening guidelines, much of what drives what age we start screening cancer at is actually cost effectiveness. Now you don't really care about cost effectiveness when you're talking about your own health and your own personal, do I have cancer or not question, right? And so, but as a society, of course, we have to take that into consideration. Someone has to pay for all of this. And so what's interesting about the UAE and how they've approached cancer screening is they've said, how old are people in our country that get this cancer? And actually, there are 45% of all cancer in the UAE is diagnosed under age 50, right? So you're talking about a very young cancer population. And so they've moved their guidelines according to their own epidemiology. We start screening with colonoscopies for colon cancer at age 40, right? And this is because the epidemiology here is different. And so I think that the opportunity we have is to try to understand how do we take something that should be an individual treatment based on that individual's biology, but also make it accessible, and really the concept of democratizing it is there. We have to address the fact that we have enormous disparities all over the globe, and you look at the United States alone, the income disparity between rich and poor counties is between 1980 and now is 38%. That's high. You look at the death rate disparity in the same time, it is 580% different. So I worked in the South Bronx, and I worked 5 miles away in the Upper East Side at Albert Einstein and at New York Presbyterian at Cornell. And you're talking about a 500% difference in death rate, right? So I think when we think about longevity and we think about chronic disease and who's affected and who's dying, our projections right now are that we will have 9 out of 10 people die from chronic disease in 2050 in our current path, right? So how do we take those top 5 of those 9 people who will die and actually identify their risk earlier? How do we take a population and screen them and understand who really is high risk? And how do we then address that risk earlier, more at the root cause of those chronic diseases, which actually do have shared pathways often, right? When you go back far enough in the biology, you're looking at changes in cellular mechanisms that lead you to, let's say, inflammation, that lead you to cancer, dementia, diabetes, heart disease, right? So there are these, if we can take it back far enough and really understand early enough in someone's change in their biology and address it then, whether that's through aggressive lifestyle, early medication, more screening, a different approach to even offering surgery for some patients early on, this is something where we can then change the path of many, many people. But we have to have that population look. We have to be able to see who really is at high risk before they end up in the hospital, and we see the consequences of that disease. So part of what I think our goal should be is, on the one hand, we have individuals in front of us that we can get a lot of information on them. We can help them understand their own biology, their own biological age, and how their own choices and paths that they're taking for their health can either take them on the direction left or the direction right. And this is where these biological age tests will help us immensely. And then we can take this on a population level and really say, okay, this is the group that's high risk, that if we do nothing in 20 years or 30 years, we'll end up in our hospitals, right? And we'll end up with premature death and high cost to the system and a burden.
So I think that most people don't need convincing that this is something that we need to do. I think it's the question of, are the healthcare systems ready for it? Are the governments ready for it? And how can we address perhaps that gap? Is it that more research needs to be done? How do we really move forward on a larger scale? And I just wanted you to talk a little bit maybe about the research that the Institute for Healthier Living will be doing to try to address that gap, because maybe that's what's needed, evidence that can be taken to the decision makers so that they can see the proof and say, okay, definitely, this needs to be backed by government.
Yeah, it's a good question. I think it always is the question of, many people at this conference and around the world, we can identify problems, and the question is, how do we then implement systems that help fix those problems? And right now, no one is paid to keep you healthy, right? The hospitals are paid when you're sick. Our incentives are aligned with that system. And so okay, we have to think about, does that mean we have to pull this out of the health system a little bit, right? Because our current health system is actually not set up to keep people healthy. Do we need to help broaden the way that research is funded, right? This is a topic I think that Andrea raises many times around aging as a disease, right? So how do we, because everything is set up around funding research about a disease, funding and reimbursing a code that is a disease. And so our system is set up in a way that the incentives are not aligned with what the goal that we're talking about. So we have to realign those incentives. And how do you do that on a societal level and with government and the private sector? To me, is really finding places that really have the goal of keeping the population healthy. And this is the beauty of what we have the opportunity to do here in the UAE with the Institute, is to be able to look at it from a perspective of a government that is very committed to keeping their population healthy, and showing that through our research we'll be able to prove that model in a blueprint. And that blueprint can be used by this health system and other health systems to be able to show these are clinically and cost-effective risk prediction tools, and these are clinically and cost-effective interventions. And how are we going to measure the outcomes of those interventions? We will be able to show biological age, we will be able to show more classic markers of chronic disease, and we will be able to show other things like quality of life and how people feel in their optimism about their future. So I think all of those things are part of our goal and what we're trying to achieve.
May I hazard the appendage of an analogy, especially precarious in this part of the world? I would argue that the elephant in the room is always the same elephant in the room. It's money, right? So profit tends to drive what happens. And I'm going to take the chance and say this even here, but essentially green energy sources are to fossil fuel as healthcare is to disease care. We have a disease care system. Yes. And so we could argue that we have to eliminate a disease care system to have a healthcare system, or we could invite the disease care system to diversify their portfolio and start investing in health and well-being because the resources are there. So I think the kind of research that can flow from a brilliant innovation like the Institute for Healthier Living can inform that transition, which can be incremental and evolutionary as long as we go fast enough for it to constitute a revolution. But it's much the same. So entities that have a significant stake in fossil fuel don't need to go away, but they do need to read the writing on the wall. Yeah. And they need to be major investors in sustainable sources of energy and then gradually shift. So they need not leave their profits behind. And similarly, we need major investment in what could truly be a healthcare industry which doesn't currently exist, addressing all the things we're talking about here, promoting genuine well-being across the lifespan and extending the health span. But the same entities that currently derive their sustenance from filling hospital beds could derive it if they own gyms and places where healthy food were readily available, and gradually shift, and ultimately we would need fewer hospital beds. This will play out over long time horizons. We're talking about decades and generations, but I could see the total number of beds per unit population gradually being dialed down as investments in health and well-being are gradually dialed up, informed by research at the population level, so that the money does not constitute a threat.
Yes.
Because when money constitutes a threat, we can all predict how people and entities, and for that matter, governments, are going to behave.
Yeah, it basically stops everything, unfortunately. So it's really about perhaps evolving and upgrading rather than anything else.
Does this mean I have to stop joking with all the cardiologists that I want to put them out of business? Because I do say that on a regular basis. So maybe I need to reframe my jokes so that they don't feel so threatened.
I think they know they have job security for the foreseeable future.
May I
yes,
add
of
one
course.
thing on that? So I fully agree with you. I think what we very often do is research on diagnostics, on interventions. We do randomized controlled trials, etc. What we do not do well, I think also in our ecosystem, is implementation science, because we have to make changes, huge changes. And it doesn't matter if we are creating an ecosystem next to the conventional system or we are modulating the conventional system. The cardiologist now also applying biological age test. But we need this implementation science because we even do not know what our consumers want. I think we only know that we have a consumer drive, but how to shift the majority of consumers who need this most, which are the ones who have a higher biological age, is, I think, the question. So there are lots of shifts to make, and I think implementation science, which is absolutely underfunded, is of utmost importance because we already have lots in hands, but we do not implement it well. So how to implement it, that research side, I think, needs to be done. Of course, otherwise WHO guidelines would be implemented already and we wouldn't talk about the stuff everybody on public health could do, and we would already be in the fine-tune session, but we are not.
And I think that there's an observation that I should bring in, which is a personal one, which I now see coming out, is that the weight loss drugs, the GLP-1s that are out there, they are now being used by private individuals and private clients, but they are now moving into the mainstream of people, not only self-paying, but they're going to be available on national health systems and insurance systems in the future. And I was amazed when I first heard that the UK government under NICE was going to allow millions of people to have access to these GLP-1s. And the question really is that what we're seeing is that governments are taking a macro view and saying, we've got a downstream problem here with all of these people that are obese. Now, there's two elements to this. Are we just trying to medicate people thin, and are we going to just medicate people healthy in the future, or are we going to try and convince them to do it the right way, the right foods, all of the things that we talked about today? So I think it's a really interesting macro market observation. Now, my observation is that in the US, the FDA is going to approve Wegovy, Ozempic as a weight loss drug, not just as a diabetes drug. I can see that starting to happen in the future. And this is good. Obviously, there are going to be fewer fat people out there, right? But obviously, it's going to cost a lot of money. Yeah. There are side effects associated with it, and it's not doing it the right way. But I think that is something that we have to be aware of, that with a lot of the therapeutics we're talking about in terms of longevity, people will medicate themselves longer lives in the future as well. So I think it's a very interesting period of time, societally and clinically, as well as scientifically, that we're moving into now.
Absolutely, and let's hope that the right choice is actually being made, I think, on a individual level and also on the population level, but that's why probably institutes such as this one here, the Institute for Healthier Living, and what obviously Dr. Andrea is doing and Dr. David, that's why it's so important to get the word out, I believe, and to build evidence-based practices, because that's really what it comes down to.
Phil, may I ask you, by your comment, might not be the right way. Mm-hmm. Why should the GLP-1 receptor agonist not be the right way to treat individuals who are obese? I agree with you, but I think I saw the audience like, what is he saying? Isn't it, if the analogy, giving metformin to somebody who just got diabetes is already pre-diabetic for 10 years, I think nobody would say it's not the right way to give metformin.
Of course. I guess I come back to a very simple chart, and if I could throw it up, I'd be delighted to share it with you. But it's basically by generation, whether you're a millennial, Gen X, or boomer, are you physically active? And in the US, more people are not physically active than physically active. Okay, so the physically active people, they're the people that we're talking about here. They're going to take their own health very seriously. Yes. They're going to get every test they can get. They're going to do all the wearables. They're going to do all the things that they want to do. Okay, but the other people, the majority of people, are more interested in whatever it is that drives their life, whether it's their Netflix, their fast food, or their drinks. And let's not forget that those large corporations are spending billions of dollars every year to convince people to stay where they are in their lifestyle condition. And the governments are looking at the silver tsunami. This is coming at them. So they're going, and the UK government's doing it. They're going, okay, well actually, what are we going to do with this group of people that are just going to get diseases of aging? They're going to get them younger in life, and they're going to be a massive burden to our society. With the birth rates going down and the tax base going down, how the heck are we going to afford to do this? So that's why they're making those decisions, and I feel that this is how it's going to expand. So I hope that kind of answers my little shocker there.
And I really do want to jump in here. Andrea, correct me if I'm wrong, but I think you're making the point that GLP-1s for hyper-endemic obesity, which we could say is a byproduct of lifestyle, is not all that different from drugs for type 2 diabetes, often a byproduct of lifestyle, or coronary disease, or hypertension, all often a byproduct of lifestyle. And I think there we agree. What I think, on the chance I wasn't provocative enough by suggesting in the United Arab Emirates that we shift from fossil fuel to green sources of energy, let me try to be a little more provocative and ask you how you all feel about the town arsonists having a partnership with the fire department. We'll set the fires, keep you guys busy and gainfully employed. You'll put out the fires, and then we'll set more fires. And then you can put them out, and we'll set more fires. Because when we talk about right, I think that's really the issue. It's not about an admonishing finger for an individual who should be behaving better. It's about the view from altitude, where much of the modern food supply is willfully engineered to maximize the release of dopamine and mimic the actions of addictive drugs. If you're not all familiar with Michael Moss, Pulitzer Prize-winning investigative journalist, I highly commend his work to you. 2 books, Salt, Sugar, Fat, and Hooked, and a New York Times Magazine cover story entitled The Extraordinary Science of Addictive Junk Food. So that's the problem. We have a big food industry around the world. This is global. It's true in my home country, it's true here, and it's true almost every place that has access to choices. The food supply is willfully engineered to maximize consumption, minimize satiety, and consequently propagate obesity and chronic diseases for the sake of profit. We're mortgaging public health for profit. And then in steps Big Pharma to make more enormous profits, treating conditions, whether it's obesity or type 2 diabetes or hypertension or coronary disease, which nobody needed to get in the first place. If pharmacotherapy for all diverts our collective attention from the partnership between the arsonists and the firefighters, then Houston and Abu Dhabi, we have a problem.
Well, thank you very much for that. I don't want to say provocative, but I just wanted to end it on a note of perhaps, and unfortunately so, the individuals seem to be collateral damage, unfortunately. And I think, as much as possible, we need to kind of take control of our own lives, and we are all individually responsible, right? So I think, even though we have so many people around here, and they would probably like to hear more from you guys, but unfortunately we ran out of time. So I wanted to thank you all for a very engaging discussion. Thank you for being here, and thank you guys also, and hopefully we'll see you all very soon. Thank you.
Thank you.